So early diagnosis is important. The question is how early. Now things are shifting even further. It appears that there is a window of opportunity. Recent evidence suggests that within the first 12 weeks of disease, or put it another way, that the first 12 weeks of disease may be an immunopathologically distinct phase of the disease. That during this time, patients are more susceptible and more responsive to treatment. That is, with the introduction of disease-modifying drugs, which may have more effect than if introduced at a later stage in terms of preventing erosions. So things are really very tight. This has been looked at to some degree, as illustrated in the second point here, that clinical and radiological outcomes, including higher remission rates, were significantly better at 3 years among a very small cohort of 20 patients started on disease-modifying drugs 3 months after onset, compared with 20 who were started on treatment with a median time of 12 months after disease onset. So the message is the same: catch them earlier, and the earlier the better, and they're likely to do better in the longer term. I was asked to say something about the new EULAR, American College of Rheumatology, criteria for classification of rheumatoid arthritis. And I've just started off with 2 slides showing the old and the new. And most of you will be familiar with the old criteria for diagnosis of rheumatoid, where 4 out of those criteria had to be positive. And if it was one of the first 4, they had to be present for 6 weeks. I'll talk more about that in a moment. And here on the right are the new criteria for classification rather than diagnosis of rheumatoid arthritis described last year. And you'll see, as I'll illustrate further in a moment, the emphasis is on the extent of joint involvement and serology. That's where the weighting lies, rather than necessarily in duration of synovitis or the active phase reactants. Serology being rheumatoid factor and anti-CCP antibody. So that if you have one high positive test, anti-CCP for example, you'll get 3 points. Now you need 6 points total to reach a situation where you can say that rheumatoid arthritis is present. So it's not very much. 3 for anti-CCP antibody at high level, and perhaps 3 for 4 to 10 small involvement of small joints, for example. Now, these criteria, as I said, were developed last year, and they were adapted, and this is why it's relevant to this talk, for early rheumatoid arthritis. The old criteria included destruction of joints on X-ray as a significant point, but this is just the type of damage which treatment is meant to avoid. So those criteria really catches patients too late. And as Gillian Hawker, one of the senior authors of these 2010 criteria, said, the 1987 criteria actually posed a major barrier to the study of treatments designed to prevent joint damage in rheumatoid arthritis. Many patients did not fulfill the previous RA criteria until their disease was well advanced, and in many cases joint damage had already occurred. And the new criteria will be incorporated into the inclusion criteria for new clinical studies, making it possible to develop effective strategies for treatment of early rheumatoid arthritis. This is the key, because clearly you need an internationally recognised standard when publishing research on this subject, so hopefully the process will be much facilitated. The declared goal and purpose of the new criteria is to make it possible to carry out scientific studies about the treatment of rheumatoid arthritis in early undifferentiated stages of disease. As I said earlier, this has previously been difficult. The intention of the new criteria is to identify among patients newly presenting with undifferentiated inflammatory synovitis the factors that best discriminate between those who are and those who are not at high risk of persistent and erosive disease, rheumatoid. And another important point, the authors repeat frequently and unambiguously that newly published document concerns criteria for classification of rheumatoid and not its diagnosis. At the same time, they recognise, or they're fully aware, that the recommendations may in the future also be used for making the diagnosis. And that is the case. These factors have already been incorporated into our early rheumatoid arthritis clinics, for example, when it comes to referral recommendations to doctors in primary care. But at the end of the day, the diagnosis, nevertheless, lies in our hands. This just illustrates really what I've said earlier. There was a point value of a total of 10 for the new criteria, of which 6 are needed to make a diagnosis of rheumatoid. The weighting has shifted. A high positive rheumatoid factor anti-CCP antibody give half the total score necessary to classify a rheumatoid.